to introduce Dr. Vikram Patel. He's a Paul Farmer Professor and Chair, Department of Global Health and Social Medicine at Harvard Medical School, and Director of the Mental Health for All Labs. As a global leader in mental health, he's recognized for transforming mental health care in low-resource settings. That is very impressive, and I've been following his work. It's amazing. As co-founder of Sangat, his community-based models have influenced healthcare policy worldwide. His work highlights the deep links between mental health, social equity, and community engagement.
Good morning, everyone. What a fabulous couple of talks we've already had this morning. And I'm hoping the perspective that I will bring today will complement those talks. The field that I'm most associated with is called global mental health. This is a discipline at the intersection of global health and the clinical mental health sciences. Our focus primarily is on addressing the large inequities and disparities in how mental health problems are distributed in populations, the access to high-quality care, and most importantly, of course, the outcomes, mental health outcomes that people experience according to their social standing in society. I am clinically trained as a psychiatrist, but today the perspective I'm going to bring is the global mental health one, which I hope will complement actually the earlier two presentations that have really focused on the individual. And what I want to really explore and reflect on is the role of spirituality and faith in the context of global mental health. Now, I train in the biomedical paradigm in London. Some of you may wonder, what exactly is this paradigm? This is a paradigm that's worked incredibly well for many health conditions like cancer and heart disease. And at the heart of this paradigm is the notion that we would interview a patient, we would examine them, do some diagnostic tests, all in the pursuit of a diagnosis. Because the diagnosis is then what our focus becomes. The diagnosis then defines what it is that we're going to treat. We lose sight of the person, we keep our focus on the diagnosis. This was an approach that's worked very well in other branches of medicine, and there's no reason for us to have believed that it wouldn't also work very well in mental health. So I trained in how to diagnose and treat mental health problems in London, and soon after my psychiatric residency, I found myself in a completely different context, that of Harare City in Zimbabwe. Here, I found myself in a country of roughly 9 or 10 million people, and I was one amongst 9 psychiatrists to service the whole country. I often look back on those days and remember that there were more psychiatrists in the corridor of my hospital in London than there were in the entire nation of Zimbabwe. And it clearly was apparent to me that everything I had learned in London had to be unlearned, and I had to start from the ground up. This is when I started exploring how Shona society had been addressing mental health problems in their cultures from times immemorial, well before the British colonized most of southern Africa. I spent many hours observing and interviewing traditional medical practitioners. Traditional medical practitioners in Zimbabwe comprise a very diverse group of practitioners, some at one end who were deeply imbued in traditional African religion, and others who had also invoked the Christian faith that had accompanied the colonists. I observed in their patients a number of very fascinating metaphors and idioms that people use to describe their distress, their social suffering. And what I saw was this inseparable connection between the mind and the spirit. For example, a very commonly used term was that my spirits are distressed. I would interview these patients, and applying my biomedical prism would easily diagnose them as suffering from one or another form of a mental health condition, most commonly mood or anxiety disorders. However, what really healed them wasn't any kind of service that I could provide, but it was, in fact, the treatment, if you can call it that, the rituals and practices that were deeply imbued in both traditional as well as Christian faith that had helped them on their journey to recovery. The narrow biomedical paradigm I discovered there wasn't just impractical because there were simply no mental health practitioners, but it was also not acceptable to the local communities that I was working with, primarily because the way they understood their mental health problem, from my biomedical perspective, a mental health problem, was actually deeply connected to their spiritual world. And so the kind of explanatory model that I was offering them was completely alien to their own understanding. In addition, of course, I must add, another reason why, of course, the biomedical paradigm was rejected was because it was so deeply associated with histories of colonial incarceration in asylums and the attendant abuse, exclusion, and violence that people experienced in those hospitals. This was also a time when the HIV pandemic was sweeping across southern Africa, wreaking devastation. Communities already living on the edge were now facing economic devastation. And this fueled enormous helplessness and hopelessness. The biomedical paradigm for mental health seemed even more inadequate to address what these communities were experiencing, an existential crisis. What these communities really needed were solutions that empowered them rather than how medicine typically disempowers communities, which addressed their social suffering head on, and which incorporated culturally approved and accepted practices and narratives in healing. Through the rest of my career, I have focused mostly on the first two of those, which I'll only speak about very briefly because I really want to attend to the final one. My most important work has really been focusing on identifying the strengths that communities have to support one another in times of distress, to support individuals in their recovery journeys, designing interventions which can easily be learned and delivered in communities, and incorporating both clinical science with local knowledge. The second part of my work has largely focused on addressing social suffering by addressing the social determinants of what shapes our mental health from the earliest years of our lives into young adulthood. Of course, this is the period, the most sensitive period of our lives, because that's when most mental health problems emerge. Along the way, though, I have begun also to reflect back on my experiences in Zimbabwe, to consider how my work might embrace the third strategy, acknowledging an importance of faith, spirituality, and religion in promoting well-being and recovery, not just in the individual, but also to address disparities in mental health at the population level. As Swamiji described, I've become very aware of the large literature linking faith with mental health in both directions. It turns out that people who have strong faith and practice religious practices seem to be protected when they face stresses in life. The very famous Nurses' Health study of nearly 50,000 American nurses has demonstrated that those nurses who had high levels of religious practice appeared to have 30% lower risk of developing depression over their life course as compared to those nurses who had no faith at all. And of course, we also see the reverse. When we're struggling with our mental health, many of us turn towards faith to find meaning. I wondered whether this could be the reason for the mental health paradox. What is this mental health paradox? When one studies the distribution of mental health problems in a population, we often find that those individuals who live in conditions of disadvantage and poverty have worse mental health than the better off. However, when you look at countries, it turns out that the poorest countries in the world seem to enjoy better population mental health than the wealthiest countries in the world. That is the curious mental health paradox, so beautifully demonstrated by the World Mental Health Surveys led by Ronald Kessler here at Harvard Medical School. I wonder whether the reason for this paradox is that in poorer countries, a much larger proportion of people are deeply imbued in spiritual, religious, and faith-based practices. And indeed, I wonder within countries, such as in the United States, this might also explain the odd paradox that African American communities, despite having faced centuries of structural violence, actually enjoy better mental health than other communities. The question really then is, what is the reason for these observations? This is really important because biomedicine really prides itself in trying to unpack mechanisms. The word mechanism is at the heart of what we do at Harvard Medical School, understanding the mechanisms through which our mental health is shaped, protected, harmed, and healed. I can think of several different mechanisms. Of course, we've already heard from our first two speakers the direct effects that different religious practices might have on brain function, for example, as Keshwan showed so eloquently, or through different kinds of meditative practices helping with emotional regulation. But I want to touch on what medical anthropology also tells us about the very important ways in which faith, religion, and spirituality can heal. The first is simply, as I mentioned earlier, the alignment of our own illness narratives with what is being offered. The vast majority of the world's people do not view social suffering through a biomedical psychiatric lens. They view their social suffering through either the social or spiritual worlds or perspectives that they embrace. And therefore, the alignment of their own illness narratives with what is being offered is a very powerful driver of recovery, quite simply because faith itself heals. And the best example of how faith heals is what we dismiss in medicine as the placebo effect. In fact, in my mind, the placebo effect is potentially one of the most powerful explanations as to how the mind and the body can heal itself. When you look at the empirical literature, for example, on psychotherapy, what's very interesting is that control groups who receive some kind of sham therapy show 50 to 60% recovery rates. Think about that. There's nothing technical in a sham therapy, and yet the majority of people recover. In fact, very interestingly, you also see this with so-called real medical problems, like, for example, angina. The landmark study is showing that sham angioplasty has the same clinical benefit as real angioplasty. Got every cardiologist in the world up in arms thinking, there goes my commercial source here. There's yet other ways in which faith can also heal. And that is, for example, by promoting social connectedness. Think about this. We all need one another to promote our mental health. And what does faith do, particularly religion? It gets us together. It gets us to do things together. It gets us to share a set of values. And by getting us to act together in solidarity, it directly addresses social connectedness and reduces loneliness, which we now all accept is a very powerful driver of mental health. And lastly, religious communities promote altruism. They promote gratitude. And we all know that engaging in community service, engaging in acts of charity, don't only benefit the so-called recipients of our charity, but in fact primarily benefit ourselves. They promote a sense of purpose and meaning, elements that are crucial for resilience and well-being. To be sure, friends, I think that the way faith and spirituality heals is through a combination of all of these factors in a highly person-centered way. The exact mix, therefore, is unique to each individual. And as with many complex things in life, unlike what very many biomedical practitioners would like to see, there will not be a direct line of causality between a specific reason and a specific outcome. So then the question that's left for us is to consider whether and how these dimensions of a person's life, the dimensions of faith and spirituality, can in fact be woven in to the biomedical mental health care system. Personally, I think we need to urgently address that. And the reason for that is that the biomedical mental health care system, predicated on this diagnosis and clinical treatment model, has its limitations. Consider the United States. The United States is the world's best resourced country when it comes to biomedical mental health care. We enjoy the highest per capita number of mental health professionals in the world. The city of New York has more mental health professionals than the continent of Africa. We spend more on mental health care than virtually any other health condition. And during the last 2 decades, every metric of mental health in the United States has worsened. We need some fresh thinking here on how we can address these mental health challenges. I believe we need the mental health system to shift its focus from the diagnosis to the person. I think most people would agree with that. Person-centered care has to be the future of the mental health care system. And if we choose that approach, we have to also acknowledge that the vast majority of people in our communities are people of faith. They deeply, deeply believe in faith. If not necessarily in an organized religious form, certainly in the sense of spirituality. Then it seems to me that the mental health care system has to go beyond addressing the brain and biological circuits and chemicals and whatever other biological theories we have. We need to address the social worlds that are so very important to people. And in those social worlds, One must engage with the spiritual world. But of course, this is easier said than done because there's such a vast gap in the narratives between biomedicine and the spiritual world. So I want to end by thinking of a few ways in which we might possibly do that by borrowing on real-world examples, including my own work. Perhaps the best examples are those that have tried to establish collaborations, recognizing that these two kinds of approaches are so distinct that really completely fusing them is going to involve dilution of one or the other approach. So instead, collaborations with mutual respect for each tradition has been one approach that has been championed in many places. For example, the Dava Dua program in Gujarat in India is a very well-established initiative that is seeking to build connections between the biomedical mental health care system and the healing dargahs, Islamic faith-based healing that happens in a very famous mosque in the state of Gujarat. That particular program has now been well documented, and hundreds of thousands of individual patients have been able to move seamlessly between the dargah and the practice. And members of the dargah have been trained on how to also red flag individuals who might benefit from medical care. In my own program at the Mental Health for All lab, the EMPOWER program, I only arrived in this country about 8 years ago and brought many of the community-based initiatives that I'd been working with in India and Africa to this country. And I discovered here, this was a country of faith. Large proportions of the people of the United States are people of faith. And I realized that these faith-based communities were incredible untapped resources that could be used, that could be leveraged to actually improve access to evidence-based mental health care. I've been delighted that over the last couple of years, we've been working with a congregation of 8 churches, diverse denominations, in the area of San Antonio in Texas. Here, through our EMPOWER program, we're working directly with pastors and faith-based communities to build the capacity of these communities to fuse their faith-based practices to support others who are going through difficult times with techniques that have emerged from modern psychological science. We already have tantalizing evidence not only about the incredible demand for this kind of skills building, but also the effectiveness of this approach. We can also think about providing holistic or integrated care within clinical settings, and the OSHA Center here at Harvard Medical School is a good example of such an effort. But even if we can't do any of these as individual mental health practitioners, at the very least, what we can do is to acknowledge the individual's spiritual world in their care plan. In conclusion, friends, the journey towards optimal mental health is multifaceted and highly unique to each individual. We need to recognize the diversity of individuals as well as the diversity of systems through which we can understand mental health, both from the biomedical sciences as well as from the spiritual world, which is a fundamental need of all humans. By recognizing and acting on the intricate interplay between the mind and the spirit, I believe that we can unlock new pathways towards building resilience in communities, as well as offering patients a comprehensive, person-centered approach to recovery. Thank you.
Anyone questions for Dr. Vikram Patel? Yes. Somebody there.
Hello, Dr. Patel. I truly, truly appreciate your integration of medical anthropology at Harvard Medical School. I'm actually taking my first medical anthropology class right now, and we just read Kleinman and illness narratives, and it's really been exciting. Just from my personal experience with Ayurveda and observations of like how women of color have been really sidelined in biomedicine and have often been, have kind of, whenever they come with their own diagnoses, they're seen as like a threat to the system. And in Ayurveda, whereas the framework is less diagnosis oriented and more about getting the person in touch with their own body and understanding their own, like encouraging them to have holistic understanding themselves. Yesterday, Sadhguru was talking about how health should become more our business and we should become more responsible over our own bodies. So I'm kind of curious about how you would encourage biomedical practitioners to integrate that holistic understanding.
Yeah, I do. I'm not sure I fully understood the question, and if my answer is missing the mark, please meet me in the coffee break. I do think that there is a problem in centering our mental distress entirely within our bodies. I think there's a fundamental problem there. If I had to wear the hat of social medicine, which is the field that I represent, I think it completely gives a clean chit to the social world we live in. And I do think by actually focusing only on your individual self-realization, you are also passing responsibility for your distress entirely to your own actions. This is honestly, it's a very neoliberal view, I think, of what our mental health is. Our mental health is profoundly shaped by our social world. In fact, if there's any science about what really shapes our mental health, it's got to do with our social worlds from our earliest years, particularly adversities in childhood, all the way through into young adulthood. And if we're really going to actually achieve mental health equity, it's going to have to be, I'd say, in addition to doing all that we do for individuals, fully acknowledging that we need to address the social world. And one approach that I found very inspiring is, for example, what NHS England, which is a national health service of that country, has embraced, is the notion of social prescribing, which very interestingly, of course, uses the biomedical term prescribing, except you're not giving them a prescription. You're actually connecting those individuals with a range of social services that can be very powerful for recovery, by the way, and that includes faith-based services.
There's one person there.
Hi, Dr. Patel. Thank you for your, it was so nice to hear you. I have a question. I'm an 11th grade student, and I noticed like a lot of my peers, including myself, we're very wary of organized religion. I think that to some extent we feel it's too rigid, too cultish, and I think that faith has such an important role to play in our mental health, and this population is specifically affected by it. So how do you recommend we can go about spreading spirituality amongst this population without necessarily going through the method of organized religion? Because I think that doesn't really work for people like us who are very stubborn and I think our receptivity to organized religion is very low, so that's kind of a problem.
Yeah, well, I don't know if I really have an answer to that question, but I will say this. I personally am very spiritual. I'm not an adherent of any organized religion. I deeply and profoundly believe that there is another dimension of my being that as Swamiji said, that I cannot measure in an objective way. I deeply believe that. And as a practitioner in medical school, I became a transcendental meditation practitioner. I did not know I would be standing here 35 years later giving this talk in Bala's conference. But so I have always had this extreme deep belief, but I have never believed in organized religion. So I don't think these are the same. They intersect, but they're also very distinct. Spirituality is a personal, private pursuit. Organized religion is both that plus the organization of our beliefs in a standardized way. And that is what young people today don't always adhere to. They don't feel comfortable being told what they need to do in order to be a good adherent of a particular faith. I don't think you need that in order to be spiritual. And I think we need to really distinguish organized religion from spirituality, because it's the spirituality, in my mind, that is the most powerful driver for our well-being.
I sincerely hope somebody will address the toxicity of social media that's at play as far as mental health goes, because we are addressing youth here, we are addressing young people, and I haven't heard enough about it or at all about it from anybody. So what would you say about the effect of social media directly affecting mental health issues, especially in the younger, and I would say in the adults as well, as I see them use it? I'm a dinosaur as far as that is concerned. I don't have any accounts, I don't participate, but with due understanding of the toxicity of this addition to our lives.
Thank you for that question. So I think you and I belong to the same age. If you're a dinosaur, then I am one too, because I also don't have any social media presence. And I have to say, I dodged the bullet. I have this very good memory 10, 15 years ago when one of my mentees said, you need to have a Twitter account. And I said, why? He said, no, because you have so many followers. I said, no, I don't have any. And in any case, I don't want to be counting them. And she said, no, I will set up the account for you. And I will post. I said, that's even worse. But anyway, I dodged that bullet because, I know there are John Touros and maybe Shirley as well, they're the real experts. They will speak on that. But I just, since you asked, I have an opportunity to give you my response. I think social media, you have to ask the question, not does social media harm mental health or not, but at what age? I think this is an extremely important piece in the conversation that is often obscured. I do believe that age matters, and that younger people, particularly up until the age of puberty, have extremely sensitive brains in terms of the developmental stage that they're in. And the way social media is designed can be very harmful for some young people. But I don't think the same risks apply in adults, for example. So I do think age is a critical piece here when we're having that conversation. Thank you very much.